Welcome, everybody. Hope everyone's doing extremely well. Excited to be a part of this quarter training with you. This will be about the endocrine system, um, and we'll also cover other topics in this quarter. Excited to plan our dates to come out and see you and do some hands-on training. Wishing you all extremely well, and we will get started.
As everyone has been so excited, we're going to talk about endocrine emergencies. I've been hearing just so many people ask me, when is the endocrine system? When do we get to talk about that? And so now is the time. Just kidding. But no, there are some pretty good things. There actually are some few things here. We're going to spend some time in diabetes and hypo and hyperglycemia. That is kind of where the crux of what we deal with in the emergency room and in your setting most often is going to be circled around diabetes and things there. So, which leads me to my first bad joke is I always say to patients, well, I don't anymore. I used to in Texas and in Arizona all the time. They'd say, I've got a problem with the sugar diabetes. And I go, okay, I'll give you $10 if you can tell me what the other diabetes is. So I never had to give anyone $10. But anyway, so we'll talk about that a little bit later too. So anyway, with no further ado, endocrine system. It really, even though it's kind of a small part and we don't think about that often, it really does influence almost every cell, organ, and function in the body. It is quite important. They often show this very broad range of signs and symptoms, and they're very difficult to treat and prevent other life threats from them. Okay. As we continue on, so some of the components of the endocrine system, just remember, again, it's responsible for the control and regulation of all the systems in the body. And some of the major components are the hypothalamus, the pineal gland, pituitary gland, thyroid, thymus, parathyroid, and adrenal glands. The pancreas and the gonads are also part of this as well. The hormones that each of these glands form are really the chemical messengers that are secreted into the bloodstream, and then these circulate throughout the entire body and target organs and maintain all that homeostasis. The hypothalamus, this is a small region of the brain, and it really contains the control center for most of the emotions and a lot of our functions. It's the primary link between endocrine and then the nervous system as well. Produces regulatory hormones, controlling the release of hormones by that pituitary gland. And then the hypothalamus and pituitary gland, they're very closely related through the vascular system. Pituitary gland this gives you what they call the tropic hormones, the adrenocorticotropic hormone, the growth hormones, those kind of situations that usually come from there. That secretes mainly there. And then also the hormones of ADH and oxytocin that become important throughout the body, especially oxytocin in pregnancy. The thyroid gland, this secretes thyroxine. And when the body's metabolic rate decreases, this is why you get people like low thyroid. We'll talk about this a little bit later on. But it's the body's major metabolic hormone. It stimulates the energy production within cells and how you use those energies and how you produce that energy. And then you need enough iodine to be able to make thyroid appropriately. And so a lot of times we'll see people with low iodine. This is why when you look at your salt, it's iodinized. It was years ago, there wasn't enough iodine in people's diet and people had goiters and had all sorts of problems with their thyroid. So the U.S. government through the FDA made iodinized salt. And so what's really interesting now is in some of these areas that are really high end, people are always using these sea salts and different things. Goiters and thyroid problems are starting to make a comeback because it's not iodinized anymore. And then these are really, the production of this is regulated by a negative feedback mechanism, basically meaning if there's not enough or too much of one thing, then it goes in the other direction. This help maintains, you also secrete calcitonin from the thyroid gland. And so this helps maintain all your calcium levels in your bloodstream. It also helps build your bones. And the kidneys then will either absorb or excrete this excess calcium. So it kind of starts with the thyroid, and then the kidneys and the bones and everything works together to regulate that throughout the system. Your parathyroid, this also helps regulate in calcium. And so a lot of times when you see low calcium levels, the parathyroid will be elevated. It acts as an antagonist to calcitonin, and then when it's secreted when the calcium levels are low, and it stimulates bone dissolving cells to release the calcium into the bloodstream. And so this can become problematic for our women, especially with osteoporosis, and then decrease the amount of calcium released into the urine. And so people with parathyroid gland issues, especially the elderly, we worry about bone fractures quite a bit because they get weak, brittle bones. The thymus gland, this really helps to identify and destroy foreign intruders. So it's really with the immune system is where this really helps out significantly. The pancreas, you mainly hear about this with the pancreatitis, folks that are drinking a little bit too much alcohol, that kind of thing. They get that pancreas that flares up on them. But there's a lot of different ways the pancreas can get inflamed as well. But it's a digestive gland that's considered both to be endocrine gland and an exocrine gland. And the exocrine component secretes digestive enzymes into the duodenum. And so it helps to digest everything there. So that's the exocrine portion of it. The pancreas, continuing along, the endocrine component really it comprises through the islet of Langerhans, is kind of where all this begins. And the cell groups there within the pancreas, they act like an organ within an organ is the way that they like to describe it, because those islets of Langerhans are almost completely different than what the exocrine function is of the pancreas. But you get the alpha cells, they secrete glucagon, beta, insulin, and then the delta cells secrete the somatostatin. And so when your blood glucose level falls, glucagon is secreted to raise it. So this stimulates the liver to change glycogen into sugar and then secretes that into the bloodstream. Then when the glucose levels are low, when they rise, insulin is secreted. So this transports glucose into the cells and stimulates the liver to take in more glucose and store it as glycogen for later use. So it's the only hormone that decreases the blood glucose levels. The adrenal gland, these are located on each side of the body, just on the superior aspect of each kidney, divided into two distinct sections, really, the adrenal cortex and the adrenal medulla. The adrenal cortex, it completely surrounds the inner medulla, and this secretes aldosterone, and that helps in response to drops in blood pressure or decrease in sodium or increases in potassium. It stimulates the kidneys to reabsorb sodium from the urine and excrete potassium. And then when it's stimulated by the hypothalamus, the adrenal medulla secretes small amounts of norepinephrine and then large amounts of epinephrine. So the norepinephrine raises blood pressure by causing contraction of the smooth muscles that line the arterioles and relaxation of smooth muscles that lines the bronchioles. The epinephrine stimulates sympathetic nervous system receptors and stimulates the liver to convert glycogen to glucose for energy, for use in energy in the cells. The result is increased levels of oxygen and glucose in the blood and faster circulation of the blood to the brain, heart, and muscles. Really, that fight or flight response is what we start to see there. The gonads, these permit sexual maturation. They fulfill reproductive needs. The testes in men, this produces hormones called androgens, and this regulates changes in all your puberty. And then the most important here is testosterone, which is huge. Now everyone talks about what your T levels are nowadays. In women, it's the ovaries. These secrete estrogen and progesterone. The estrogen signals the anterior pituitary gland to secrete LH, or luteinizing hormone, when an egg is developing in an ovarian follicle. And then both these assist in regulation of the menstruation cycle. At puberty, estrogen supports the development of the secondary sexual characteristics for women. And then the progesterone prepares the uterus for implantation of a fertilized egg, is really where that focuses upon. So we can't take these super lightly because they do affect so many different systems. And you're seeing signs up, you're going to, obviously address the hazards, you're going to follow your standard precautions, and then check for any home medications. That's, especially if they're altered or not telling you a good history, as can be the case with these situations. Home medications, if we can find those, that's so huge for both of us, what we're trying to do. You want to identify and manage your life threats and then form a generalized impression. And this can be seen so your signs and symptoms depend on the hormone production and secretion that is affected by it. So is the patient alert, or do they have an altered mental status, right? If unresponsive, They may be experiencing endocrine colitis such as hyperglycemia or hypoglycemia or myxedemia coma with severe thyroid deficiencies. Sweating or diaphoresis can be a sign of severe distress, and that's present in thyrotoxicosis, along with some other pulmonary edemas and multiple other things. But if the thyroid is having severe problems, then a lot of times we can see this as a problem as well. There's certain signs and symptoms that you can look for that can help us, and when we're looking for different things. This buffalo hump and moon faces, we see this with Cushing syndrome. Mottled skin can be associated with pancreatitis. Enlarged or abnormal body parts, that can occur with your SIADH, or the syndrome of inappropriate antidiuretic hormone, and that can give you some anasarca with myxedemia coma as well. Underweight or overweight may indicate endocrine dysfunction such as hypothyroidism, hyperthyroidism, or diabetes. Exophthalmos, this is when the eyes protrude out. This is very common with Graves' disease that we see fairly often there. Again, primary assessment with most everything else we're looking at, we're going to airway and breathing. Ensure that patent airway, investigate breathing sounds, assess for their effort, etc. On the circulation, you want to take a look at that skin color. Is it moist? Is it hot? Is it cool? Get a blood pressure. Do they look pale? Or do they have a moist or a cool skin? It could be a sign of shock or hypoglycemia. If they have a hot or dry skin, it could be fever or hyperglycemia. And so then we can get some IV fluid and replenish blood as needed and be prepared for that here in the emergency department. The transport decisions. A lot of these patients, at both Logan and at Brigham, they're going to be coming to Logan Regional Cash or Brigham. You're not going to take these folks to a specialty hospital immediately. So they're going to come to your regular facilities. So you want to just transfer them rapidly to the closest facility as possible and get them sustained in the ER. Anything that we can use in our history taking is very helpful, especially in your diabetic emergencies. If they're unresponsive, you want to grab that blood glucose level ASAP, right? And then manage DNA abnormalities appropriately per our protocols. But some signs and symptoms to think about, especially if they're undiagnosed or if they're poorly managed. They can have polyphagia, polyuria, or polydipsia. And we used that when we talked about that little girl. If you guys remember that, I think it was a 9-year-old. We made her come in the middle of the night and had to travel all the way down after seeing me in the ER and then having to go down to primaries. And in the history that the parents gave, that she had been eating and drinking a lot and then peeing a lot as well. But that was the only history. She was undiagnosed at that point. The hyperthyroidism and thyrotoxicosis, these can cause cardiac dysrhythmias, especially tachycardias or PVCs or PACs. Anything in the atrial system is very common, so AFibs and flutters can happen with this as well. We want to try to get an idea of any allergies that we might have prior to any medication. So as you talk to them, anything that you give them, they may have allergies. For some reason, they just run higher in this population. And then document any of the medications you find, any ones that they're currently taking, or whether they've been compliant with that regimen. And then in the females, ask them, especially in their childbearing age, ask them about when their last menstrual cycle was. So on our secondary examination, it's very important that we kind of get a look at the overall appearance and position of the patient. What's their general appearance look like? How did you find them? And identify as many atypical findings as you possibly can at the time. You want to do a focused examination. Usually not necessary unless you see the trauma patient there with that. So you want to do kind of full body scan first and then manage what's life-threatening. A lot of times with the trauma, and you've heard me talk about this before, is sometimes we go straight to the injury. But on these, you want to kind of get a glimpse of the entire patient, which I think is always necessary and always right. And then from that point, then you can focus in on what's going on. But some of the conditions of the skin, you may be cold and clammy. That could indicate that you have shock or a severe hypoglycemia. If they're cold and have a dry skin, It could be overdose of sedative drugs, could be an alcohol intoxication possibly. If they've got hot and dry skin, that could be a heat stroke or fever or hyperglycemia. Just a lot of different things that can go on here. If the patient's comatose, try to determine whatever level they are. Are they alert? Are they oriented? Are they not? A lot of times we use the GCS scale on this, which is okay. GCS technically is for trauma. However, everyone knows it and everyone can communicate with it, and so it makes a lot of sense to us as we use it. When I was in residency, we had a doc that would always kind of make fun of us if we used the GCS for anything besides trauma. And anytime we were presenting in lecture, if we said GCS of whatever, he'd get all after us. Is this patient a trauma patient? We go, oh, sorry, Dr. Horwood. So I'm not going to do that to you. I think we all understand it pretty well, so I think it's a good way to use it. But we're going to look at the vital signs, right? First of all, really looking for, are they bradycardic? Are they tachycardic? Are they hypertensive? Are they normotensive? That can suggest in a hypertensive bradycardic patient, that could suggest intracranial pressure. We want to look for abnormal breathing patterns, like a Shane-Stokes, right? That's going to be pretty common in a non-neurologic source of a coma. A Kussmaul respirations, for example, that would be somebody in a DKA type situation. And then some of the more worrisome abnormal breathing patterns include like a central neurogenic ventilation, huffing and puffing, but they don't seem to be moving any air. That could be a lot of different problems there that they may have. If there's any respiratory related motions, are they sneezing or yawning, or they have hiccups, that can also indicate a brainstem injury or brainstem damage. That can be problematic for our patients as well. Once you have them in the rig and you're moving, we want to continually reassess the patient. Be prepared to manage that airway at any point in time. And if you can, we want to take a look at that glucose fast we can in the diabetes. And then a lot of times there's going to be emotional support. They may be confused, they may be scared, as may be the family. Then also monitoring any cardiac rhythms as well as we go along. And then just like we do with any comatose patient or any other patient that's severely ill, recheck those vital signs, recheck the pupils and their level of consciousness and see where they're at. If they have altered mental status, I think almost always we go ahead and start at IV and get some NS going for the patient. If they've got a glucose for less than 60, we're going to treat with your D50s. And we've got our protocols for that. So we just follow those protocols as we see fit there. And then if it does not improve after any dextrose or anything there, then maybe it is a narcotic overdose. We consider naloxone. But usually you're going to see some paraphernalia there, some other things there. So you guys know really well on that, so you follow your judgment on that. If we're going to transport them, if they're going to be intubated, I think we probably put them supine and maybe even put that cervical collar, because if we're concerned about any trauma there, if they're not intubated, then just get a stable side position for them. If we're worried about intracranial pressure, get that head elevated to 30 to 40 degrees and keep them midline the best we can. And then keep the mouth very free of secretions and vomitous blood, that kind of thing. Some of these metabolic derangements, especially speaking of glucose. So the endocrine disorders are caused by hypersecretion of a gland or insufficient secretion of these glands. Basically, it's overactive or not active enough, right? That's kind of the situation that we have with our patients. With the glucose metabolic derangements, these are usually caused by dysfunction of the pancreas. And so it's just the body's inability to metabolize glucose. These definitely can result in a compromise of the ABCs, and they often cause the fluid balances to be off. That's why in your DKA patients, we give a lot of fluid to start off with them as they become extremely dehydrated, especially extracellularly. You'll get a deteriorating mental status, as mentioned there, and then some abnormal vital signs, and the blood glucose level will often change. Okay, diabetes. This is a group of complex metabolic disorders. You got diabetes mellitus, gestational diabetes, hypoglycemia, hyperglycemia, DKA, and HHS. So there's kind of the 5 major things that we see and talk about a lot of times. We're going to get into some of the details of this. So this is a metabolic disorder in which the body's ability to metabolize simple carbohydrates is impaired. Okay, you're going to see these patients, what they're going to come in is with polyphagia. This is increased appetite caused by the inability of glucose to be transported across the cell membranes. So your cells are hungry, even though your body's not hungry anymore. Polydipsia, you get significant thirst. This is caused by dehydration brought about by an increase in your diuresis. And polyuria is passed through large quantities of urine containing glucose. That glucose is an osmotic. It sucks that urine across and then kicks it out through the urinary system. Glucose is the primary fuel for cellular metabolism. So along with oxygen, the two main things that we really, really need. Characterized by the body's inability to sufficiently metabolize glucose is what diabetes mellitus is. And so in people with this disease, either their pancreas does not produce enough insulin or the body's cells do not respond to the effects of the insulin as produced. In either case, there's an elevated level of glucose in the body or in the blood and glucose in the urine. And that glucose will build up and flows out of the body. And then that glucose acts as a diuretic and your urine increases. And then the cells basically starve for glucose in that continued situation. This figure shows how glucose is unable to enter the cells in a diabetic patient, basically kind of showing that glucose just staying in the capillary and not entering into the body cells. So some of the life-altering complications of diabetes, kidney failure, the glomeruli, they become sclerotic or they become basically scarred and don't function the way that they do. So diabetes is the principal cause of kidney failure. You get necrosis of the papillary tissue, and then nephropathy, and then officially you have renal failure. High levels of blood glucose may result in this decreased kidney function over time. Next is you have heart disease and or stroke. Adults with diabetes are 2 times more likely to die of heart disease or to have a stroke. When it's not properly controlled, the lipolysis raises the level of fat in the blood, so you become dyslipidemic, meaning you have significant amounts of lipids in the body, which gives you increased risk for atherosclerosis and coronary artery disease. You also get microscopic deterioration of the vessel walls, called microangiopathy. It's a condition in which swelling of the membrane walls restricts flow of blood to the organs and the tissues. Basically, that causes ischemia of those tissues. That ischemia leads to necrosis, which is death of the cell tissues, and then you have the scarring. The central nervous system damage can cause a cardiac dysrhythmia as well. And then the microangiopathy and the neuropathy continue to increase, and it causes a risk for a silent myocardial infarction. And so sometimes people won't come in with the chest pain or the pressure or the tightness. They'll feel differently in these diabetics. They'll say they have abdominal pain or they feel nauseated or a little shortness of breath. And so we kind of assume an acute myocardial infection until proven otherwise in a lot of these patients, if that makes sense to you. Some of the other situations, strokes and hypertension, the vessels basically are damaged again by that microangiopathy, and that characterizes cerebrovascular disease. And then you have an increased incidence of stroke. The peripheral artery disease impairs circulation to the lower extremities. This is why they start to get the tingling in the toes, and also the same reason why they end up losing toes and legs and things like that, because they just don't get the blood flow to those tissues, and they get necrotic and die. Hypertension is also present in 2 out of 3 patients with diabetes. The eyes, this is a big concern, and it causes the primary cause of new causes of blindness in the adults. The high blood glucose level causes damage to the vessels of the eye. And then scar tissue may pull that retina from the eye and actually give a retinal detachment. And then cataracts form when fructose and sorbitol are deposited in the lens. Coming back again to the neuropathy, the nerve damage that results in loss of sensation and function here often affects the peripheral nerves first. So you get a diminished sensation and function in the extremities. So you get paresthesias and dysesthesia, and that can blunt your pain reception. This also causes ulcers to go unnoticed, and they become very infected. You can get gangrene to the adjacent tissues due to this very poor circulation, and infection may spread all the way to the bone, causing osteomyelitis. That's when we need to amputate them. Many conditions can be delayed or prevented if we get some good lifestyle changes, and then we continue to manage with them. Blood glucose levels are more difficult to control during physical activity and also during high stress levels. But the chronic and acute complications are associated with diabetes. There's a lot of different things here that we can consider, but more severe in people who require insulin is what we typically see. And then if we leave these things untreated for some time. You get organ system dysfunction, the DKA, wasting of body tissues, and then death as well. And then you can get some of these really severe complications, the average blood glucose level and the age of onset, that can make these become more severe as they go along. And then there's really no cure, unfortunately, for diabetes. But we can try our best to control the symptomology from it.